ICD Online is an all-new digital platform for college communications, providing greater outreach and engagement with fellows in the dental community worldwide. ICD Online has live and recorded webinars, videos, and online content. ICD Online offers innovative means for connection, education, and research in an increasingly virtual world. I am Christine Benoit, and I am an international counselor and a fellow in the International College of Dentists. I am chair of the projects committee. It is delightful to see you all today. Today's webinar will discuss antimicrobial resistance worldwide and describe the primary causes of antimicrobial resistance. Viewers will learn the connection between antimicrobial resistance and the COVID-19 pandemic, the threat of C. difficile, and learn about the importance of antibiotic stewardship methods. Please submit your questions to the Q&A box, and we will get to as many as possible. Both panelists and the question and answers will be a maximum of 1 hour. It is impressive you are joining us, and we welcome colleagues worldwide. ICD applauds you. I will introduce our first panelist. Dr. John Tullner is the International College of Dentists Dental Safety Program Scientific Director, and he was instrumental in initiating the ICD Get Smart About Antibiotics program. Dr. Tullner has lectured nationally and internationally on infection control and bloodborne pathogens. You may download Dr. Tullner's presentation by clicking the link in your chat box. Dr. Tullner will inform you of the public health crisis that, per the World Health Organization, describes as a slow-moving tsunami, antimicrobial resistance. Dr. Tullner, you're on.
Thank you, Christine. Can everybody see okay? I'd like to welcome everyone this morning to the presentation, wherever you are and whatever time it is. And again, we hope in a short period of time today to really do something like restaurants have a taste of different things. Well, this is a taste of antibiotic resistance because we don't have a lot of time. But I would like to at least whet your appetite for a number of things and a number of references that you'll be able to access to get information you will need. But in 20 minutes, we can only cover so much. The first thing I'd like to talk about is a report that came out from the Secretary General in the United Nations. And if you check the date on this, it's April 2019. No time to wait, securing the future from drug-resistant infections. This report was a groundbreaking report. It calls for a number of things to help, at least what nations can do to help combat antimicrobial resistance. And we'll talk about that in a moment. International organizations were all involved, and it was stated that in this particular document, 10 million people are expected to die by the year 2050 if something is not done about antibiotic resistance. Now, having said that number, first of all, these numbers are very hard for us to grasp, at least they are for me. But if you think of a number as probably a low estimate, it's very, a little bit better in terms of how you look at this. For instance, if you look at the number up here, the one they state of in 2050, 10 million people will die, that's a close estimate, but it is an estimate, okay? So as we go on. The other thing is, this report stated there'll be very stress the financial systems. 24 million people will be in poverty by 2030, and it will greatly damage our economy as well, worldwide. If you look at the date of this, which is down below here, this was May 27th, 2016, almost the end of May and April. And the superbug that doctors have been dreading just reached the United States. Now, some of the things I will key toward the US because I have greater access to the CDC, but this was just a Washington Post article, one of our newspapers. And in that time, the first identified person, a 29-year-old woman from Pennsylvania, had an E. coli organism in her urinary tract that could not be treated with even the most effective antibiotic for that, which would have been colistin. Keep in mind the date and think of where we are now. This was only, what, 4 years ago, and we had just started the International College of Dentists program on antibiotic resistance in January of that year. In the United States, a report came out again in 2019. This was from the United States Centers for Disease Control and Prevention. Very important report because it had updated information from 2013 to 2019, and the numbers have been underestimated from the numbers of infections and deaths for antimicrobial resistance at that time. And the one that this reported essentially reported that in the United States, 2.8 million antibiotic resistance occur every year, and 35,000 people die as a result of those. Now, to put that in a little easier way for you to understand, hopefully, is that means about every 15 seconds, someone in the United States acquires an infection, an antibiotic-resistant disease. And every 15 minutes, it's 11 seconds, but every 15 minutes, someone dies of an antibiotic-resistant disease. Now, another thing I'll say about statistics, and I'll say it now, because we're going to be looking at them, but 35,000 people is a lot of people, but that's an estimate because when the death certificates are written and you're dealing with something like COVID-19, it could be a combination of things. So these numbers are probably low, and at any rate, they're sufficient enough to get our attention, but realize that sometimes that there are comorbidities that are involved in the death. So how it's assigned is a different story, and that really depends on where you are and the public health folks in your area. Okay, I want to make one distinction right now, and that is between antibiotic resistance and which means resistant only to bacteria. Antibiotic is antibacterial. Antimicrobial, on the other hand, is resistance, refers to a number of organisms, bacteria, viruses, and fungi, the one we'll be most interested in. And there's also parasitic. So keep that in mind, because when people say antimicrobial, many times they use that interchangeably. I personally like the term antimicrobial because it covers viruses such as COVID, such as the flu, and also fungi such as Candida albicans, things like that. But fortunately, we don't have that right now, but there is another Candida organism that is pulmonary that is on the top list. Okay, this is just an example to show you that bacterial infections can be things like strep throat, food poisoning from salmonella, but those are the only two you see up here that are bacteria. Now, they can be treated successfully with antibiotics, but viruses such as the common cold, flu, COVID, athlete's foot fungi, and parasites aren't treatable by antibiotics. They either have to be vaccines, antiviral agents, or antifungal agents. So keep that distinction in your mind. And just briefly again to reiterate, this is a global threat. This is not a threat to the United States. It's a global threat that affects all of us. And we, as healthcare providers, really have to take a lead to help educate not only our staff and our patients, but even our colleagues and folks in the area that we know. I, for instance, recently did a 7-minute presentation for Facebook for our local library. All these things help get the word out. Okay, another important document I'd like you to take a look at here, and you can get any of these documents online. That's exactly where I researched them out. They are provided by the CDC, or you can make copies of these. But this was an action plan that was proposed by a global action team from the World Health Organization. And if you notice again, the date on this, we're talking about May 2015. And this was right before we again began the ICD plan, but that's when this issue of antibacterial resistance was really gaining steam and became a hot potato. This global action plan said a few things, but I'm going to read it to you because I want to make sure that we understand. The goal of this plan was basically to ensure, as long as possible, that continuing a continuity of successful treatment and prevention of infectious diseases with effective and safe medicines that are quality assured, used in responsible ways, and accessible to all who need them. Having said that, many countries, you can actually buy antibiotics over the counter. So this becomes a much harder problem to address, but it's important that it's being addressed worldwide, not just in the United States, not just in Europe, but worldwide. This slide depicts some basic facts about antibiotic use. The first one is that antibiotics are lifesavers. Sir Alexander Fleming in 1928 accidentally discovered a mold on one of his plates, Petri dishes, and it turned out that he had discovered what is now known as penicillin. And penicillin was the first antibiotic. It really became used heavily in World War II, but at the time that Sir Alexander Fleming discovered this, he stated that this was likely to become a resistant organism if not prescribed in the appropriate doses and properly. And he predicted exactly what we're in right now, which is a antimicrobial nightmare, really. Number two is antibacterial treats only bacterial infections. We just discussed that. Number three, can you get better? Some ear infections don't need antibiotics. That's just an example. Number four states that antibiotics do not help with sore throats unless there's a secondary organism. Antibiotics are not necessarily or should not be written for green sputum. And finally, there are risks with all antibiotics that we take. When we prescribe an antibiotic, we're putting someone at risk, and we'll talk about that. This is just to show you that 70% of the antibiotics that are written are appropriate, but 30% are not indicated. And again, these are estimate numbers. But interestingly, of the 70% that are indicated that are written, of the 100%, of those 70%, a significant number are not appropriate for the organism that's being treated. So keep that in mind. This is a big problem. When you write, make sure you try to target the organism. You try to use narrow spectrum where possible, and this will help us reduce the amount of antibiotic-resistant organisms. And then the goal they have here is by 2020, 50% of the bacteria will be gone. This just lists, and I won't read them all to you, I'll read a couple of them, but this is common side effects that are associated with antibiotics. I'm sorry, let me go back. These are side effects you can expect. Anything from mild skin rash or hives, that type thing, to fungal infections such as oral candidiasis or vaginal candidiasis. The more severe reactions include everything up to anaphylactic shock. And I'm not going to read all these to you. Hopefully you can see them. But there are two very important ones I want to stress other than anaphylactic shock. And one is diarrhea, and associated with that, there's an organism you'll hear about later from Dr. Zwischenbaum, and that's Clostridioides difficile now, and it's an infection that sets up a situation that is very susceptible to sepsis and death, and you'll be hearing about that. 9 out of 10 of people that think they are allergic to penicillin are not allergic to penicillin. Can you feel better with antibiotics? Yes, many times you can. But it is important, and we'll talk a little bit about hand washing, but it's important to, in every infection control endeavor, to be appropriate hand washing. We're seeing that with COVID right now. We're seeing cover your coughs, that type thing. All these things are common now, especially with COVID. How does antibiotic resistance happen? I'm going to play you a short video here. And what these are infectious organisms. You give an antibiotic and one organism can survive, and I'm going to play it again because when it does survive, I hope I'll play it again. Well, I guess I won't. When one organism does survive, it becomes what you call a mutation and it produces other organisms. And this is how antibiotic resistance happens. There you go. So the antibiotic comes in, a mutant organism becomes a resistant organism and produces others. And by the way, every single time you give an antibiotic, you develop resistant organisms. Every time. This is just a chart I'm not going to get into in depth, but it talks about farm animals, which are a very important source of potential infection with antibiotic resistant organisms because they're pumped full of antibiotics. And the second one is an individual, George, that's in the hospital. He gets an antibiotic resistant infection, and he can either go out into the community and spread it, or he can go through the hospital and nursing home system and either acquire it through people that don't wash their hands properly, which is the primary problem with Clostridioides difficile, and then he can spread it to others that way back into the community. But again, hand washing is a primary, very important part of every infection control endeavor, and particularly with Clostridioides difficile, but also with everything. And you're seeing that again, this is the most important thing with COVID-19, the virus we're dealing with internationally. I'm not going to read this because I'm running short on time, but this is a dental slide that you can get from the CDC. Anything you see with the CDC logo here, you'll be able to acquire, and it tells you 7 steps that you can do to help fight antibiotic resistance. These are do's and don'ts of antibiotic safety. Do's and don'ts are very evident, but not always in our mind. And you have to tell patients, for instance, don't skip your doses, don't share your antibiotics with others. Take them the way you have to educate the patient. Take them the way the dentist intended you to take them, and take the complete dose. And do tell your dentist if you have an allergy. Do tell the dentist if you're taking other medications because they interact with antibiotics often. And do tell your dentist if you have side effects of any kind so they can take precautions and talk to you about that. Sharing is important. I want to mention Antimicrobial Awareness Week, which is a worldwide event in November, and it's important that you share what you can with others during that week. This in the United States they're celebrated at the same time this week. You can mark this down, but you'll get it. Week is November 18th to 24th. It's your chance as a leader, as an ICD fellow, to really get involved. Take advantage of this. There are a number of things you can do. If you have any questions whatsoever, you can address the International College office and get more information on that. And I'm sure they'll be glad, or I'll be glad to help you if you want to try to contact me. That's fine. But if you go to the CDC website, you'll see more information about toolkits and other things you can gain. One last thing I want to mention before my time is up here is the important connection between coronavirus or COVID-19, and it's really a time bomb right now with superbugs, because the former chief medical officer, Dame Sally Davies, urges hospitals to avoid overuse of antibiotics to stop patients from catching secondary infections. So we're in a kind of a bit of a catch-22. The patients need antibiotics because of secondary infections, and at the same time you can create antibiotic-resistant organisms if you're not careful. And finally, this is, again, Dame Sally Davies, and if you haven't heard of her, she's a very important person in the UK and an excellent presenter. She has been the chief medical officer in the UK until 2019, I think September, and then she became what is more like a drug czar. She is now the special envoy on AMR for the UK. But try to go on YouTube and see one of her talks. She's amazing. And her quote is, "Antimicrobial resistance, where antibiotics no longer work for some serious infections and already pose a greater threat to humanity than coronavirus. And that says a lot. And she's a very, very excellent researcher. And finally, I'm just showing you what we gave out. We have these rubber grips, but basically, again, this is how I'd like to say goodbye. Again, try your best to get a grip on antibiotic resistance. And at this point, I will turn the program back to Christine Benoit. Dr. Benoit?
Pardon me. Thank you, Dr. Tollner. John, that was fantastic. It was a most informative presentation. It's a pleasure to introduce our second presenter, Dr. Samuel Zwetschgenbaum. Dr. Zwetschgenbaum is a dental director at the Rhode Island Department of Health. Sam holds a Master's of Public Health from the University of Michigan and a certificate in gerontology from the Rowan School of Osteopathic Medicine. You may download Dr. Zwetschgenbaum's presentation by clicking the link in your chat box. Dr. Zwetschgenbaum will discuss the need and the importance of antibiotic stewardship and good patient communication. You're on, Dr. Zwetschgenbaum.
Well, good morning, everybody, and thank you so much for this opportunity to talk with everybody today. It's really been a pleasure to be involved with both John and Christine in our small committee for ICD on Get Smart About Antibiotics. If you haven't yet visited the website, I'd encourage you to, because there's a tremendous number of resources. And just like Dr. Tollner said, part of us giving this presentation this morning is to let you know about these resources. For example, on the left side of the website, you can see that there is a 1-hour video that you can do for CE credit. And on the right side are resources, some of which I'll discuss shortly, but I can share with everybody honestly that every few days I get an email either from John or Christine that they've discovered something, a resource, whether it's from Massachusetts or California or England, anywhere around. I think they're doing a huge favor for the college by, again, scouring the globe for resources. And this is because their commitment is so strong. And I'm happy to be part of this group now because of our commitment together to all work together for dentistry to play leadership in addressing these true crises. And the good news, though, is that things are working. There is change in the world. For example, we discussed a little bit about C. diff infection. I'll go into that. For those not familiar, it's a gut infection that's often attributable to antibiotics. You see two lines here. The top line shows the rate of overall of C. diff infection over the last 5 years. Unfortunately, there hasn't been much change. Still about 500,000 people in the United States have C. diff infection. The good news is the white line, that's hospital-acquired C. diff infection. So it shows if efforts are made, and in hospitals they're making significant efforts, if efforts are made, they can work. So this is from a recent article, shows that efforts work. Also what's working is efforts towards antimicrobial resistance. So for a number of bacteria, for example, vancomycin-resistant enterococcus, methicillin-resistant Staph aureus, or MRSA, we can see that over the last 5 years or last 6 years, there's actually been a decrease in the number of cases here in the United States. That's the good news. Unfortunately, the bad news is there are other bacteria that are increasing. So the work's going on, but it needs to continue. One example is a bacteria called ESBL producing Enterobacteriaceae. These are on the rise. What does ESBL stand for? That stands for Extended Spectrum beta-lactamase. So these are bacteria that actually destroy antibiotics, because as you remember, penicillins and cephalosporins, those are all beta-lactams. So if you have a bacteria that actually destroys, as a beta-lactamase, that destroys an antibiotic, that's going to be a huge problem. And I think using some of the tools that are increasingly available is important. And as John shared, the World Health Organization has great resources. This is an example of some of their resources. I'd like to focus your attention on number 4 and 5, which says only prescribe and dispense antibiotics when they are truly needed, and then prescribe and dispense the right antibiotic at the right dose for the right duration. There are actually some pretty good tools out there. This is an example. This is from University of Illinois, Chicago School of Dentistry, that established a clinical decision support tool that people can use. And again, I think looking back on many of our careers, we all know that early on, it was almost like a gut reaction. You see a patient presenting with dental pain or dental infection, perhaps you couldn't treat them, or perhaps you did treat them, and our gut reaction was, let's go ahead and prescribe an antibiotic, not really thinking about whether it was truly necessary. Well, this protocol that University of Illinois Chicago School of Dentistry instituted resulted in a 73% reduction in their prescribing of antibiotics in their urgent care clinic. They went from 8.5% of everybody who presented getting an antibiotic to just 2.3. So to me, that's an example of antibiotic stewardship, looking closely at each and every patient, asking the questions before having that gut reaction. We talked about C. diff, and we'll talk a little bit more about it, but C. diff is a significant condition that affects 500,000 people in the United States every year. It can affect people of all ages. About 1 in 6 patients who get C. diff will get it again in about 2 to 8 weeks. And then it really does affect those over 65 most significantly. It tends to be a problem more in older adults. People on antibiotics are 7 to 10 times more likely to get C. diff while on the drugs and during the month after. So people have to watch closely. Also, extended stays in healthcare settings, especially hospitals and nursing homes, also increase risk. So these are the risk factors: antibiotics in a healthcare setting and age 65 and older. Ways that it's spread by people touching surfaces. So C. diff spreads when people touch surfaces that are contaminated with poop from an infected person, or when people don't wash their hands with soap and water. And it also can happen in healthcare facilities during patient transfers. So we're all working together. You've seen now the logo of Be Antibiotics Aware. So thinking about antibiotics, using the tests that give the most accurate results, identifying, and this is hospitals, identifying and isolating patients with C. diff, and of course, wearing gloves and cleaning. So how did I first get interested in C. diff? It actually wasn't a patient of mine. It was actually from a friend, a colleague, actually a lawyer by the name of Diane. Diane called me up about her father, who had been in the ICU for about 10 days with a significant C. diff infection, ultimately resulting in some outcomes I'll talk about in a second. Her father had gone to the dentist, and the dentist assessed an upper wisdom tooth that needed extraction and determined that he did not feel comfortable doing it at the time and wanted to make a referral to a local oral surgeon. Since the oral surgeon couldn't get him in, the dentist prescribed a clindamycin prescription for 2 weeks, 300 milligrams every 6 hours. Why did he give clindamycin? Because the patient reported a penicillin allergy. Now, the dentist did say to the patient, you could have, that there could be some complications with this medication, so just be aware. Ended up, the patient took the medication, he began having diarrhea, he ended up continuing to take the medication, ultimately had a significant C. diff infection in his gut. He was hospitalized, he had to have the majority of his intestines removed, and now he's on, then he ended up on colostomy bags, and he ended up living with Diane and their family, who became a significant impact on his quality of life. So what did I fail to tell you? Mr. L's wife, she had passed about 6 months before. Whenever Mr. and Mrs. L went to an appointment for Mr. L, she was basically the listener. She was listening to everything. She took down all of the information that the doctor said was important. He'd never need to listen. So even though the dentist told him, it didn't make it. So despite giving the warnings, it was never received. I want to think about what could have been done differently in this case. I guess the first thing I'd say is maybe the dentist could have taken out the tooth. I know there are dentists who are comfortable doing extractions, dentists who are not comfortable taking out the extraction. If it is an extraction that can be done at the time, imagine saving somebody from not having to take an antibiotic, from not having the risk of a C. diff infection. The dentist probably could have assessed the need, perhaps just given ibuprofen or other pain med. There's more research, recent article in the ADA or journal ADA that showed that antibiotics aren't always needed when there's pain and infection. The third thing is better communication. And we'll talk a little bit. The real good news is there's a whole toolbox of strategies for communications with older adults. Our population is aging, and communication strategies with older adults are critical, not just for describing treatment plans, but sharing with them any potential complications. So my asks of you are, if you are up for it, refresh your oral surgery skills. The other thing I would like to encourage you to do is some efforts towards antibiotic stewardship. I'm in Rhode Island, and my neighbors just to the north is the great state of Massachusetts. Their Department of Health developed this antibiotic stewardship toolkit, and I know, Christine, I think this is a resource that you helped post on the ICD website that people can visit. And if you go to the website, you'll see, and you'll be able to review this, that it says they encourage everybody to make a commitment to optimizing antibiotic prescribing and patient safety, implementing a quality improvement initiative, at least one policy in your practice, and perform a stewardship review on 10 patient records. So what this gives you the opportunity to do is do a self-audit, to go through 10 patient records and look at several items that are listed here. And I'll take a minute to walk you through this. So if you go to this website, you open up the tool, you can download these sheets, and it has sections on informed consent, medical history, and then in the diagnosis, it asks you about your diagnosis and radiographs and what was done, and it asks you to review the indications for antibiotic use. I'll give an example in a second. The other thing that goes over is the treatment, asks you questions about your treatment, and then finally asks you to do a stewardship review. So I think if fellows were to go through this for 10 charts, I think it would be very enlightening and perhaps inform you on things you can do for quality improvement. So I'm just using this as an example. You would go through, did you do an up-to-date medical history? Yes. Was there a history of recent medical or dental treatment that required antibiotics was documented? Well, that's something maybe we don't always ask. We don't always ask about any other treatment for which somebody may have taken antibiotics. Again, asking what were the steps for diagnosis, and then just checking off why did you ultimately give the antibiotics? For in this case, it was because of delayed treatment or specialty referral, and very commonly patient expectation. Our patients, especially our older adult patients, are expecting an antibiotic, and it may take a little bit more education if we go through the decision tree and determine it's not necessary. So again, if you use this tool, it'll ask you about treatment. And again, in this case, I just put some examples. And again, the dosage and duration, we have some resources also. Most people were taught give for 7 days. Why 7 days? 7 days because that's how many fingers we have, or that, or that's how many days in the week. We're learning more and more that perhaps the appropriate duration, if an antibiotic is indicated, is just 1 or 2 days after the symptoms disappears. And we're actually learning this with COVID, that after symptoms disappear, another day after is what we want to continue. So we go through all the methodology here, and this is a tool you can all use. The other tool I shared with you that if we don't already have it posted on our webpage, we can, is something from the Gerontological Society of America called Communicating with Older Adults, Evidence-Based Review of What Really Works. And there are a lot of fantastic tools, items here that they're evidence-based measures of how to communicate with older adults. I'll just give you some examples. And I want to apologize. I'm actually going to be walking upstairs now. I've just realized my power is running out on my laptop, so that's a little crazy. But for the first thing is use visual aids such as pictures and diagrams to help clarify and reinforce comprehension of key points. So what you're seeing right here is a picture of my bathroom. Why am I showing you my bathroom? Because if you can can encourage your patient to put up a sign that warns them that if they have a complication, to do something about it. So in this case, it says, Joe, if you get diarrhea, stop the antibiotics and call Dr. Jones. And it has his number. Imagine if for Mr. L, the dentist had done this and put a sign so that as soon
Hello, something's happened at Dr. Z's, so let's go ahead and proceed with the question and answers, and then he'll jump online. Are you hearing me okay? Okay, great. Anyway, we have a few questions, and the first one, and it'll be for Dr. Tullner. We have a fellow from the Canadian section who is wondering if there's ongoing research on the use of bacteria that produce biotoxins to fight other bacterial infections, essentially using bacteria to fight bacteria. Dr. Tullner, you have to unmute. Yeah.
Can you hear me now? You hear me?
Yes. All set.
Okay.
Thank you.
I would have to say that there's a lot of research going on in this area other than just getting new antibiotics. One of the problems is getting antibiotics on the pipeline. which isn't a moneymaker for drug companies. But to answer your question, I don't know specifically what is going on in that area where you're using bacteria, but there are so many different things going on that would not surprise me. There's a lot of work, and I get things almost daily handed to me by my wife or someone that will talk about some effort to work around the antibiotic pipeline and revamp some of the antibiotics that we already had. And I apologize, I can't give you a direct answer, but there are a lot of things going on there. And if you'd like to contact me, I'll try to get the information for you. Thank you.
And I have a tidbit to add about that. The International Federation of Pharmaceutical Manufacturers and Associations has issued an urgency on this worldwide public health threat. And they have contributed $1 billion in July 9th in Geneva, in Berlin, in Tokyo, and in Washington, DC. They put together a big coalition of important associations to address this, because there's a longstanding paradox that the economic and societal damage from so many people dying worldwide, and that the foundation of medicine is going to be lost, whether you're having your third molars removed, a joint replacement, an organ transplant, or cancer treatment. If the antibiotics are not working, it could be absolutely fatal. So this research is the money is going to go to biotech companies and small upstarts to help, particularly with the end stage of antibiotic development. And their goal is that by 2030, there will be 2 to 4 new categories of antibiotics. So that's very encouraging. And
Christine,
so welcome back, Dr. Z. So we have another question here. This is from a practicing dentist and academic in Sydney, Australia. He's shocked at the attitude of some of my colleagues towards antibiotics. I commonly hear it's only one script, or what difference can I make? What can we do to change this attitude? I suppose that I'm more affected by this because I'm undertaking a PhD studying metagenomic surveillance of the oral rhistome. Do you have any comment for this practitioner in Australia? Sam or John, you go ahead.
Yeah, I can take one crack and then give it to Sam, but I would say one thing you can do is show them some data, and that again is kind of hard to grasp. But again, stating that one person every 11 seconds, this is in the US, but they probably have data in Australia, acquires an infection, and every 15 minutes somebody dies of it. The other thing is, if they had a situation where they knew someone, such as Sam's case or other ones, if you go to Peggy Lillis' story, show them the video on YouTube about the Peggy Lillis story. And it really will bring it home to them. That's a very graphic, well-done video by her son. It's a school teacher who basically was given an antibiotic, probably clindamycin, for a root canal procedure, and subsequently got C. diff, and 6 weeks later died. But the video makes a strong statement. Go ahead, Sam. You have
I would agree. And again, I apologize for everybody for losing you for a second there. But again, I think what we're seeing now, especially with COVID, is the importance of everybody working together as a team, whether it's in people's practices that everybody has to work together to have processes in place, or in terms of everybody wearing a mask regularly. We do these things so that our future is brighter. I get it. Educating our colleagues can be challenging, but I think for this one, we can't be selfish. We have to all work together as a team. And I think the other thing is educating our patients so that our patients don't expect antibiotics. And once I think a practitioner hears from a patient, hey, I don't want that antibiotic, they're like, oh, the message is getting out. So I think we have to handle it sort of from both sides.
Okay, thank you both. Great insights. We have another question right here. Our local orthopedic surgeons are telling our patients that they need to take an antibiotic prophylaxis prior to all dental treatment for life, all capital letters. The ADA doesn't recommend this, and science doesn't back up this recommendations, but patients are caught between their physician's recommendation and our understanding about the science of antimicrobial resistance. How can we deal with this problem? Which of you? Okay.
Yeah, Christine, I'll take a shot at that first and then let Sam comment on it. But I was a hospital dentist for my career. And the thing is, if way back when, and this goes back about 40 years, when I was asked to set up the protocol for that when it was recommended for joint replacements, I worked with a gentleman at the hospital I was at who was a retired Navy surgeon. And the first thing he said to me is he said, "John, do you realize we're prophylacting lawyers?" That's a long time ago. Since then, it's been shown, and if you look at the ADA, American Dental Association recommendations, they were done with the group from orthopedics. The problem is getting orthopods educated. And I think if you can contact the individual and hopefully educate them a little bit and use the guidelines that their group established with the American Dental Association, that would be one avenue. I will tell you, I know of a lot of situations, good dentists that do prophylax because sometimes people haven't heard the most recent recommendations. And that's why it's important for you to spread the word to as many people as possible. And Sam, would you like to comment on that?
Yeah, no additional comment. I mean, I think there are some surgeons who may be sort of stuck in their ways, who may be aging out. And kind of my hope is that some of the younger surgeons and physicians, just like dentists, are concentrating more on evidence-based practice. I think the younger physicians are, and it may be that there are, you know, this whole practice of evidence-based medicine and evidence-based dentistry. I think once people, you know, take that to heart, then they're going to do the right thing. But if there are people who are trusting, you know, what they've done for years, we may need to wait for those folks to age out. So.
Thank you both very much. We have another question here. I'm concerned about a lawyer saying, "Doctor, why didn't you prescribe an antibiotic for your patient who died? What would a reasonable doctor do? I'm afraid that our treatment is being affected or directed by attorneys." Comments, gentlemen?
It goes back to what I just mentioned happened to me with a surgeon at a VA hospital I was working at. But yeah, and there's a lot of things. We have an expression in the United States, CYA, and I won't express it other than to say, you give antibiotics just to make sure nothing happens. You protect yourself. You cover yourself. And, you know, there were probably times in my earlier career when I did what Sam was talking about. And if I go back and, you know, we can't go back, but if I knew what I knew now, I would be approaching it differently. But I really never heard of, and I taught infection control throughout the country, had never heard of antibiotic resistance until around 2015. So, you know, it's a matter of educating people. And again, if it's legal, if you have a defensible situation, I'm not a lawyer and I'm not going to make a recommendation, but I would consult somebody. And again, you know, I don't have a legal answer, and I don't know if Sam has any further comment on that.
I don't, but just to say, having the work that we've done on the ICD webpage or guidelines that the ADA has posted, those are things that you can stand behind. So, you know, if a lawyer does bring it up and you say, hey, look, these are things that have been established by reputable organizations that are evidence-based, that's strong. That's strong. So guidelines and a full web page with evidence, the CDC, the World Health Organization, all those things are backing up what we do.
And if you do prescribe something inappropriately, you'll be in hot water too. So it's good to cover yourself in both directions.
Exactly. And, you know, I know I didn't get to finish a couple of things I wanted to say, but that father of my friend, I mean, ultimately he passed, but this became the rest of his life was spent with a colostomy bag. Fortunately, he wasn't litigious or anything like that. But again, that's the other side of things. but just knowing that you can impact somebody so significantly by prescribing should be also the thing you have to balance with.
Yeah, Dr. Schweschenbaum, if you want to proceed with the remaining slides, you're welcome to. We have sufficient time, about 6 more minutes.
Okay, great. Yeah, if folks would allow that, it's going to take me a second. I'm going to go back to sharing. I'm going to do this, and this will allow me to just cover a couple of more points. And when we last left, I was showing you this sign that, again, older adults, because of some cognitive changes, whether it's sort of mild cognitive impairment, having something that jogs their memory is critical. The other point, and this comes also from this Gerontological Society of America booklet, Communicating with Older Adults, is the idea of Teachback. And I learned about Teachback also because it was something I was teaching at Rutgers Dental School, and they have a whole course now for dental students about communication. Most of us didn't have courses about communication, but we realize now this is incredibly valuable. And one technique is to ask open-ended questions and genuinely listen. Use teachback strategies to assess understanding. So what if the dentist had said to Mr. L, okay, so we've gone over some potential complications of the clindamycin, some potential side effects. What are you gonna do if you get if you experience diarrhea? And then he could have had him repeat or teach back what he said. So perhaps he might have said, I'll stop taking the medication, I'll call you. Or in this case, this example, what did I say are ways to avoid getting C. diff? And the patient would say, okay, I can take a probiotic. If I have any diarrhea, I will stop taking the antibiotic. And in this way, the dentist now has a feeling that the message they've tried to share with the patient has gotten through. So I think that's important. So that was actually my last 2 slides, and also encouraging people to go back to the website, visit it, and just be confident that our team, and of course we're happy to have others share things on our team, our goal is to keep that updated with resources that are valuable for you.
That was wonderful. Thank you so much. We have another question. You spoke about being more specific in prescribing antibiotics for specific bacteria. In a clinical setting, we have to make a decision on the way patients present clinically without lab results. What resources do we have to clinically determine what the bugs are? Is penicillin preferable to amoxicillin for dental infections due to the narrower spectrum?
Well, one thing I can comment on is the American Dental Association has put out some pretty clear guidelines, I think. Christine, I believe you had them as a handout at one time. I think they might be on our website about how to manage what antibiotics you give when you don't know what organism it is, because you can't always culture. Sam, do you have any comments on that?
I don't. No, I think exactly. I think just following the literature. But you're right. It's not possible to culture, but at least to assess, and also assess the topic of time. I know, Christine, you had attended a presentation where they talked about that our gut has always been for a certain period of time where that may not be evidence-based.
Yeah, I would always consult with the physicians to make sure that their team, their nurse practitioners, if they get to see the doctor, we're aware, has the patient already been on antibiotics for pneumonia or UTIs or other conditions, so that it's it's a good decision and to benefit the patient, not to overwhelm their microbiome and get them in a spiraling condition of dehydration and all those side effects that affect the older people and younger people too. So this has been a very, very exciting day for the International College to share information with colleagues in Canada, Australia, India, South America, Europe, the Philippines, and the US and Africa. It's been exciting for the college to share and disseminate this information that will potentially save lives and improve the quality of health. We hope you stay tuned to additional ICD online programs that we will be having in the future. If you would be so kind as to take our 5-question survey at the end of the presentation so that we have feedback to improve and serve our community better. So on behalf of the ICD antimicrobial team, all of us, I wish you a good day, good health, and thank you for joining us.